triage your patient's information needs to ask them what to expect. And no, I do not know what's on your exam. So again, the goal of this discussion is to allow you to be able to evaluate your patient's health, reduce any risk of morbidity as they will be coming into your chair so that you can do certain procedures. So you want to make sure that your patient, whoever it is optimized properly for you to be able to do procedures on them. There are different standards that we follow based on the Joint Commission for Accreditation of Healthcare Organizations, JCO, and then we also follow standards based that have been provided by the American Society of Anesthesiologists. So first, the main thing you're doing is obtaining the patient history. So you've probably seen something like this in clinic. Okay. You've probably seen something like this in your clinic on Axiom, probably different color, but you're getting a detailed history of their name, first and last name, date of birth, a good phone number, a good address. This is just to help you contact them, especially because you're going to be the main ones that are contacting them here at HUCE. You want to get any other dental history, any medical history, and this, collecting all this information will help you get a generalized idea. So, okay, can I treat this patient today? Do I have to defer them to tomorrow? Do I need to get more information before I can treat them at a later date? So it's very important that you kind of have a system to follow that system to be able to help you triage your patient. So what do you need to obtain when you're getting history? You want to get their medical history, you want to get their past surgical history, any allergies they may have, whether it's to food or drugs, their social history, so that ranges from, do they smoke cigarettes, do they smoke marijuana, especially in DC, that's a common thing. You ask somebody, do they smoke, and they'll tell you, oh no, but then you have to go deeper and be like, do you smoke marijuana, that's important. Do they drink alcohol? Social history also includes, where do you work? You want to know if they have a stable situation at home, do they live with anybody, do they live by themselves? It can kind of clue you in as to what's going on with your patient. Any family history, they have a history of hypertension in their family, a history of cancer, that can also give you an idea as to how to better treat your patient. And then a review of systems is just a way for you to methodically go through each system, so cardio, respiratory, and just see if they have any symptoms. And those symptoms will help clue you into if there's anything going on with that patient currently that can also make you see, okay, well maybe they have an underlying condition, they might need to go to their primary care doctor, let me refer them out, or as you may go on. So again, this is just an example of review of systems. What should we look at? So you start off with constitutional, you ask them, hey, are you having any fevers, chills, any recent sweats, recent weight loss, fatigue? Then you go down to any headaches currently, dizziness, any fainting spells, do you sleep at night properly? Then you just go down pretty much ears, eyes, nose, oral, neck. This is of course specific to where we're working, but then you can also go further into, have you had any chest pain recently? Do you have a hard time breathing? Do you need something to help you breathe? Are you able to go to the bathroom? So like when you ask them those questions, they can help you clue you into there might be something else going on. So this is just another form of what it may look like. I think in Axiom it has a different way where you just literally click each box and attach it to your introductory note. The ASA classification, so this was formed by the American Society of Anesthesiologists. This helps us determine what class the patient goes into and what type of treatment we can then give them based on that status. So this is also for the safety of the patient. Now, if a patient is an ASA 5, that's not someone you want to be in your office that you're just going to do a filling on. That's someone who may have chronic renal failure, they're getting dialysis, they also have congestive heart failure, they're probably not keeping up with their dialysis treatment, so they're patients that are pretty much, or they have like some sort of other condition going on. They have multiple medical conditions not properly being maintained to the point where the person is not even expected to survive. They might be on life support. Or, you know, you can have your 18-year-old who comes in, has no medical history, they just play sports, they're pretty healthy. One thing that you might have is someone who is extremely healthy. So you can have a 30-year-old female, she comes into your office, she has no medical history, but she smokes. That automatically puts them at an ASA 2 because that is a significant health risk factor. So risk factors can include smoking, doing other activities that can limit their health status. important to note because for those of you who might decide to go into oral surgery, if you're sedating you're sedating a patient, this is important because you're not gonna sedate somebody in your office who is in ASA 4 without getting proper clearance. And even if you do get proper clearance, you might have to take them to the operating room. For those of you who might be going into general practice or any other type of specialty, this is also important as well because this person who has had a stroke or who has had some type of stent placed can come into your office like, Doc, I'm in pain. And if you don't factor this in, they can be at risk because you also have certain guidelines for the type of local anesthetic you can give them as well.
Yes, so I want the class to be aware. I think the main problem you guys have, you just don't know how to study. For instance, there's a lot of information here, and these are the foundation. You guys will build knowledge on this. This topic, on the chapter 1, part 1, right? Part 1, chapter 1 on contemporary oral surgery book. 20 pages, right? There's all the diseases, but they are short, so they're not into very detail. So if you have to first understand that chapter, cover it, which is a part of it, you have to look multiple times. This topic, the whole chapter, the systemic diseases that we're gonna talk about, you just can't master it by reading one time, okay? And probably you won't be able to answer the questions correctly on the exam, okay? And that will be your lack of preparation, okay? If you put enough time, I'm just saying that you have to spend time. So each of you, when you're studying, have to read this multiple times from at least one source or multiple to understand, to make it your own. So when we ask something, give you a medical condition and ask you to classify, if you didn't really make connections in your brain, you won't know. So I'm just letting you know, this whole topic, you have to spend time, multiple times, revisit, okay? And understand and make it your own, all right? Because it's a lot of details, the whole topic, right? So it's a lot of reading you have to do, a lot of thinking you have to do, a lot of comparative studying you guys have to do, okay? Just to be able to, at least pass an exam. So if you cannot pass an exam that has not very difficult questions, that's like a preparation, all right?
Okay, so now we're going to be switching gears and talking about the management of patients with different compromising medical conditions. So first, starting with the cardiovascular system, there are so many common risk factors to consider when a patient has a cardiac disease. This could include diabetes, hypertension. These all can precipitate a patient to starting to have some type of cardiovascular condition. And so it's very important to get a detailed history. Some of these patients, they might need to get an EKG so they can see how their heart rhythm functions and if there's any other underlying condition. Some might need to do an exercise tolerance test based on what their cardiothoracic person recommends, or just on your physical exam, just being more thorough in assessing them. Because certain patients, they might appear to you with maybe like distended jugular vein. Those are important things to clue you in that there might be something else going on. So first, we're just going to talk about general anxiety reduction. So these people, they come into your office, they're like, I don't like the dentist, I have an issue with you guys, they have severe anxiety, so their heart rate is already just severely elevated, higher 100s. So things that you can do to help them when they come into your office is you can prescribe them what we call like an oral anti-anxiety medication like midazolam. So before the appointment, what you can do is write them a prescription that they take the night before. Obviously, they cannot have anything to eat or drink because this medication, because of how it is, it's like an anti-anxiety medication. It can have a risk if they do have anything to eat and cause like aspiration, things of that nature, which can be concerning for you when you're practicing on them. So then they can take it again the morning of the surgery, which can help them be comfortable. So they'll sleep comfortably at night, they're not anxious. Then in the morning, they take something before they come to your office. If they're comfortable, you can get your procedure done, numb them up, and then they can go about their way and go home. While you're doing the procedure, so because you give them this medication doesn't mean that they're completely calm, it's just that they're calm enough for you to work on them. So during the procedure, you want to then talk to them, reassure them, make sure that you're letting them know. Some patients like to know what's going on at each step of the way. Hey doc, tell me when you're giving me your local. Hey doc, let me know when you're doing this. Some people are just like, don't tell me anything and just keep working. So you have to kind of feel out your patients and then make sure that you have enough local anesthesia on board. If you do nitrous, make sure you have adequate nitrous coverage. Or if you're doing IV sedation, make sure that you're giving them the adequate medication to make them comfortable while they're doing surgery, these patients, if you give them any type of oral anxiety medication, you want to make sure they have an escort with them. They cannot come to your office without an escort. Ubering to home is not acceptable. They have to have somebody in the office with them, who can stay with them, who can take them home and monitor them. Because again, there's a risk of airway concern. So once you're done, give the post-operative instructions to the patient as well as the escort, because more than likely the patient's not gonna remember most of the things that were discussed. So this is just a brief overview of, general anxiety protocol, because again, these patients, their heart rates are probably high with anxiety, they cannot be calm in your office, so you just wanna make sure that you have that under control. Next here, we're gonna be talking about hypertension. I know you guys haven't heard of Dr. Mack yet? No, okay, it's probably gonna be later, but this is one chart that she hogged for me when I was in dental school, and it was important. Every class we took, this chart always popped up to know the different levels. It changed probably a couple of years ago. This is what the standard is now. So it's important that you know what is normal blood pressure. Once you know what normal is, anything outside of that, you can determine to see whether or not, okay, this patient might have some type of hypertensive level. And then there are patients that come to your office and their blood pressure does go up just from seeing you walk in the door with your white coat on. That does happen, that is common. But there are some patients that they might say, hey, I'm on 2 blood pressure medications, and they come into your office and it's still 180 over 110. If you took your medication this morning, it would not be that way. So it's important that you understand these numbers and what they mean, as well as understanding what is an emergency and what is urgency. So someone who has a hypertensive emergency, they have acute and severe elevation of their blood pressure with newer onset worsening organ disease. So it can be something going on with their liver, their kidneys, but then for urgency, they have the same issue, but they have extensive organ damage. These are not people you want to treat in your office. Their systolic blood pressure is 180, greater than 180, and their diastolic is greater than 120. You have to take at least 3 readings of blood pressure per the ADA before you can deny a patient treatment for their blood pressure, because you want to see if their levels either go down or go up. Now, Dr. Dillon, forgive me, oral surgeons, we tend to have a leeway. Of course, I'm not touching anybody like this, but if you come to me and you're 160 over 69, I will treat you. I will change my maneuver in terms of how I give my local anesthesia when I'm treating you. But if you're, 160 over 99, I'm gonna take your blood pressure again, because I wanna make sure your diastolic more than anything is downtrending. If it doesn't go down and you go up to 100, and I take it a 3rd time and it goes back down to 94, then there's something going on, and I want you to go see your primary care doctor. So then that's where you now have to write a medical consult.
But here, because, they're learning general dentistry, and unless they do oral surgery or anesthesia, they will not know, they won't be able to sedate people, the way we teach, yes, as an oral surgeon, she's right. I mean, 160 over 70 here, your faculty can say you're not doing it, but because we are able to manage that through IV stuff, it's not a reason for us to cancel. But as a general rule of thumb, you have to know those numbers.
I think for you guys, this is your cutoff here. If they're higher than 140 or higher than 90, this one doesn't let you, you have to refer them for a medical clearance. But you have to get at least 3 readings to determine that this will be. And so what do you recommend? So depending on the levels that they have, so this is for, if they have moderate, so let's say they have 140 and the diastolic is higher than 90. You want to make sure that they see their primary care doctor. Some patients, they just might be in so much pain that no matter what you do, if they go to their doctor, their blood pressure is not going to go down because of the amount of pain that they're in. So you want to make sure that you monitor their blood pressure at each visit. Recommend they go to their primary care doctor. If you have to do something for them on that day, if it's just a single tooth, it's something you feel like you can take care of, you need to make sure that you only give 2 carpioles of lidocaine with epinephrine. Even then, I sometimes just err on the caution and just use carbocaine because that has no epinephrine, so it won't have any vasoconstrictive effect on their vessels. When you're sitting those patients in your chair, you want to be gentle with how you move your chair. Don't put them down too quickly, put them up too fast. That can also have an effect on their heart effects. For patients who have a higher blood pressure reading, you want to defer any elective treatment. These patients need to be optimized by their doctor. Reason being, if you touch a patient whose blood pressure is significantly high, their diastolic and systolic are both significantly high, there is a chance that they might stroke out in your chair. And if that happens, now it's on you as a doctor as to why you did not realize that there was some type of hypersensitive crisis going on, and you want to make sure that you get them to their doctor as needed. I know this says refer to all masturbation surgery for emergent problems. Again, we will also evaluate that patient to make sure that they're medically optimized before we do any type of treatment. So angina pectoris, this is another type of cardiac condition where it's a reversible ischemic heart disease. Patients feel like their chest is tight, they're having a substernal sensation, so you might hear like, oh, my chest is paining, I'm having tight chest pain. So you want to make sure that once you notice that this patient's having a chest pain tightness in your chair, make sure you have nitroglycerin tablets ready. There is a acronym called MONA, and I think it's ONA now, it might have changed. ONAM, so you want to give them oxygen, make sure they're breathing, because you want to make sure they're having adequate supply of their oxygen through their arteries. You want to make sure that you give them the nitroglycerin tablet, so you can give it to them sublingually, or you can have a spray available. This, if it's done sublingually, it goes faster to the bloodstream, and this will help clear up any tightness that's causing any. It's a vasodilator essentially. Then you give them aspirin. This is another anticoagulant, and then morphine for pain. It's very painful, but once the patient is comfortable, you want to see how they're doing, and you just want to make sure that you either call 911 if it's not resolving, so that you can make sure they get the adequate care that they need. You want to consider using nitrous, and that is also another vasodilator that will help them be comfortable and relaxed. Monitor their vital signs, and just limit the amount of epinephrine that you use. So you don't want to go more than 0.04 milligrams. So myocardial infarction, this is the big brother to angina pectoris. This is when there's ischemia resulting from oxygen-demand supply mismatch and causing myocardial cellular dysfunction and death. So this is like, it's gone to the point where nothing is resolving them. So it's still the same protocol that you give them. However, now you need to definitely go to your doctor and make sure you're getting some type of treatment, because if you still follow the same protocol, make sure they haven't had any invasive dental care 6 months before you even treat them. Follow the same steps, and if there's no relief, call 911 of course. And if you're not able to get them comfortable, maybe they might need to be referred to an oral surgeon, but they need to be optimized by their primary care doctor beforehand. So let's say someone's had a history of a stroke. These patients are more susceptible to future strokes in the future. So, and these patients are often on what we call anticoagulants or antiplatelets. So that means that they have a risk of bleeding in your chair. So you want to make sure that you get a medical clearance. You want to make sure that they are given the proper instructions on how to stop that anticoagulation, and that their primary care doctor provides that information to you as well. So you check with the patient, hey, did your doctor tell you to stop this for however many days? When did you stop it? Okay, well, once we're done with the procedure, your doctor told you to continue on this day. So it's very important that you get a medical clearance, that you also talk to the patient and their primary care doctor to understand how to properly manage them in the chair. And then, of course, with working with them, you talk to the patient, make sure they're comfortable, make sure they're able to tolerate the procedure. If you notice any changes at any moment, just stop the procedure, give them a moment, and just talk them through. And documentation is very important as well. And if they have any deficits, sometimes these patients may have some type of weakness in their body, so you want to make sure you note that and see if there's any changes that may occur. So this arrhythmias, these are when there's uncoordinated contractions of the heart. So this could be due to many reasons, prior cardiac disease, open heart surgery. Atrial fibrillation is the most common form. So you want to make sure, again, with these patients that you have a better understanding of what medications you're taking. So again, are you on any type of anticoagulant? Most patients might not understand that, so you can ask them, are you on any type of blood thinner? Anything that they told you need to take for your blood. Sometimes these patients may be using like a pacemaker, so you want to make sure that whatever you're doing has no effect on that pacemaker as well. And you always want to monitor their vital signs. So before these patients have any procedure, at least for us, what we do is get a medical clearance from their doctor. We request that they get a recent EKG, or their doctor send the most recent one, so we can at least see what the rhythms have been, and then give us recommendations as to what type of anesthesia we can give them locally. But again, you want to limit it to 0.4 milligrams, 0.04 milligrams of epinephrine. So congestive heart failure, again, this is when the myocardium is diseased, is unable to meet the body's demands, or there's been excessive demands that have taken place. So, the body is not able to deliver the cardiac output that is demanded. So there's an increase in the end diastolic volume, which can cause different things such as like pulmonary edema, hepatic dysfunction. They can have different types of conditions. So with these patients, it's very important that you ask them, hey, can you sleep with more than 2 pillows, or is that typical for you? How is it when you walk up a flight of stairs? This will clue you into, are they having shortness of breath? Can they breathe comfortably on their own, or do they need support? Do they use oxygen at home? Do they have any edema on their extremities, especially their lower extremities? They have a swollen ankle, because there's fluid accumulating somewhere, and there's congestion of their breast or congestion of their chest. They can't sit. So you have these patients sitting in your chair, wheeling them back. They're not able to breathe because everything is sitting on their lungs. So you want to make sure that you get, if you need to, if they are not well controlled with their congestive heart failure, you want to defer to them medically improve. Of course, make sure you have oxygen available, because again, these patients have a difficult time breathing. They might even be using oxygen baseline at home. Again, talk to them, walk them through it. Avoid putting them completely flat. So if you're working on the maxilla, I know we're told to like lay them completely back so you can see. You might have to just sit them, you might have to kind of sit them at like a 90 degree or almost 45, because you can't lay them completely flat. Any questions before we jump into the pulmonary system? Keep going? Okay. So again, with the pulmonary system, there are different things that we can see. There are complications like atelectasis, pneumonia, bronchitis, bronchospasm. If a patient has a recent upper respiratory illness, you want to delay the case, and you want to wait at least 2 weeks before you treat them. Things that you can possibly see from them on physical exam could be signs of wheezing, decreased breath sounds, dullness. So especially for patients who have asthma or COPD, they can experience wheezing when they're expiring their air. So you want to make sure you listen to that, because that's another thing that's concerning for putting them in the chair. This is just showing you Mallampati score. This is very important for when you're putting somebody to sleep. You want to see complete visualization of the soft palate. That's class 1. Class 2 is complete visualization of the uvula. Class 3, visualization of the base of the uvula. And class 4, you can't see the soft palate at all. Out of all 4 of these, which ones do you think would be a concern for putting somebody to sleep?
3 and 4.
3 and 4? Yeah, I agree. Because if I need to get into their airway and I can't see the back of their throat, that already puts me in a compromising position, So I want to make sure, I get a better understanding as to how am I going to treat this patient if I need to put them to sleep. But this is also important for you when you're treating somebody, putting a mouth guard back there, making sure they're breathing, because again, we keep this patient's mouth open and they're breathing, and we want to make sure that they have an open and paying airway.
Okay, so go back to Mallampati 4. So when you're thinking Mallampati, it's not only what you can visualize. Yes, this is based on what you can visualize, but in the back of your mind, you are thinking what I cannot visualize. For instance, if you cannot see soft palate in class 4, Mallampati 4, what are you directly looking at? What is visible to you in this oral cavity? Hard palate, okay. So you can't see the uvula, you can't see the glossopharyngeal arch, right? So always think what I'm not able to see. So higher the Mallampati score is, you actually are not able to see the structures that you're able to see in class 1 and 2. You see? It's visibility, but also in the back of your mind, what is not visible. So that when you memorize 1, 2, 3 for Mallampati, or when you have a question, you won't confuse it, right? If you study by doing comparison.
And this is just an overview of what what sounds you can expect to hear in what part of the lung. So if you're hearing grills, that's usually towards the base of the lung. That means that somebody may have fluid in their lungs. So again, congestive heart failure and pneumonia. If you hear bronchi, that's usually towards the top of the lungs, apex of the lungs. So that means it can clue you into having COPD. Same with wheezing, it's kind of where the bronchioles, and that means it could be experiencing asthma or bronchitis. So these are things to just clue you into when you hear certain sounds, what to listen to. And it's very easy to go on YouTube and look up what these different sounds sound like, so that you can have an idea. It's like, oh, okay, I heard this on your chest. Like, do you have asthma? Do you, some patients you ask if you have medical condition, they'll tell you don't sound too good, or you sound congested, like, oh yeah, I have an inhaler that I take every day. Okay, now let's go down more lines of questioning.
Did this class take history and physical from any other discipline? Physical exam? No? D1 year, there's nothing. D2 year, this is the first time it's covered, yes?
No.
No. Yes or no?
Yes,
I-
we have.
This is the first time the topic is covered?
No, we've
No, it
gone
was
over.
covered before.
Yeah.
In what course?
Perio,
Perio course?
yeah.
Okay.
Alright, so again, patient comes into your office, they say they have asthma, it's very important to get a lot of detailed information. You wanna ask them, you know, when were they diagnosed, when was the last time they had an asthma attack, when was the last time they had to use their inhaler, have they ever been hospitalized, and if so, when was the last time? The reason why you ask all these questions that I can clue you into, okay, if they're frequently using their asthma inhaler, that means there's more going on. They might not be completely controlled, they might need more than just an inhaler, they might need a nebulizer, which can help control that asthma for that time. Also, these patients, if you are working on them, they could get very anxious in your chair, which can cause them to go into having an asthma attack. So what we do for patients, if we're sedating them in oral surgery, we know they have a history of asthma, we tell them to bring their inhaler, or we have an inhaler for them. Because we don't want anything that can cause them into having an attack, because that's a risk for airway for us, and they can have a bronchospasm in our chair, and that's very detrimental. So you always want to make sure if it's not well controlled, they've recently had an attack, they've recently been hospitalized, you defer that to when they are starting to feel better. You always want to listen to their chest. You want to use any anti-anxiety protocol. Nitrous helps. You want to avoid using any medications that can cause respiratory depression. Which for us is we tend to use medications that help bronchodilate the lungs, so that it can have that ability for air to pass through. And then if they're taking steroids, you want to make sure that you have that managed as well. Because sometimes people might be on like Tessalon pearls or prednisolone because of their asthma, depending on how severe it is. So these are things you just want to factor in as well. And then you want to use avoid the use of NSAIDs in asthmatics, because that can cause bronchoconstriction as well. So ibuprofen is not typically recommended for these type of patients as well. Same thing with chronic obstructive pulmonary disease. This is usually, you see these in like older people who have a chronic history of smoking cigarettes. Sometimes they may or may not be on oxygen at home on baseline because they're not able to let air in. So you want to make sure, again, you follow the same protocol. See how they are, if they haven't been properly treated with their nebulizer and inhalers at home, to make sure that they get that properly optimized. And then you just pretty much listen to their lungs and follow the steps of and just follow the steps as stated before you continue to treat them. So it's pretty much the same for asthma. Now going on into the renal system, so you might have patients that come into your chair and they're like, you know, oh, I get dialysis twice a week. And like, oh, we're getting dialysis for it. They have some type of renal failure going on. And that is important because with dialysis, there are certain times that you can treat them. So for anybody who comes to your office and they have dialysis, you want to make sure you know what day, because then your procedure needs to be done the day before their dialysis treatment. Reason being, with the dialysis, they're wasting away all the products that their kidneys are not able to remove. So anything you do, like you're doing a root canal, you do a filling, all that irrigation that we do, those things, as much as we try and suction them out, they can still go into the system. So there's a way for, if we do their treatment the day before dialysis can get rid of that waste as well, if they're not able to metabolize it out of their system. So it's very important that you get these people the day before their dialysis treatment. And then you also want to avoid NSAIDs in these people as well. If they haven't had any, if their dialysis was just done on Wednesday and they come to you Thursday, then just do it on Friday, because they usually follow a Monday, Wednesday, Friday routine, or a Tuesday, Thursday, Saturday routine for dialysis. Same thing for renal transplant patients. They're typically not on dialysis, but because of their transplant, you want to make sure that they are properly optimized, because it's easy for them to go into failure of that organ. So you want to make sure if they have not been cleared from their transplant surgeon, that you get proper clearance. You want to avoid the use of drugs that can affect their kidneys, that can be toxic toxic use to their kidneys. You want to monitor their blood pressure. You want to consider screening for hepatitis B because again, that's a common viral disease that can occur in dentistry. So you want to make sure that they're not at risk for that because that can also be a potential harm to their organ. And if needed, find out if they need any type of prophylactic antibiotic as well. Same thing with hepatic insufficiency. I'm going from renal to liver disorder. So if anybody's having any liver disorders, pretty much the same thing. If the cause is with hepatitis B, you want to make sure that you take the proper precautions, gown up properly, don't expose them to anything that can elicit a response, avoid drugs that require them to metabolize through your liver. So in these type of patients, you wouldn't want to give them Tylenol. And then avoid situations where the person might swallow large amounts of blood. So it's very important to protect the airway. Your suction needs to be properly effective in order for them to be able to tolerate these procedures. So now going into the endocrine system, we have the big gun, diabetes. These patients come into your office. So we know that there are different types of diabetes, which is type 1, which is the insulin-dependent diabetic type, where these are typically coming from your patients that have, it begins during their childhood or adolescence and there's underproduction of insulin. So you want to make sure that there's a balance between what they're intaking and their insulin dose. So with these patients, they might have like a monitor or a pump. Sometimes it's usually on their hand or their arm, and they'll tell you, oh yeah, I get this amount for this day, etc. For type 2, this is not insulin dependent. This usually begins in adulthood. This can be due to different things, weight, activity. So some patients, they can be pre-diabetic based on a certain number. So there's a number when a patient comes in and they tell you they have type 2 diabetes. It's called your HbA1c, which is your glycosylated hemoglobin. It's very important that you ask these patients, hey, when was the last time you had this number checked? Some patients will be like, oh, it's been a couple months, I don't know. But for someone who has type 2 diabetes, they're more than likely going to sit in the range between 7 to 9 for their, if they're well controlled. The normal range that we want to see is below 5.7. That's safe standard. But for people with type 2, it's very rare that you're going to see them in that 5.7 to 6.4 range. So if they tell you like, oh, my glycosylated hemoglobin is 7, I'm not too concerned with them. That means they're controlled, they're taking their medication. But you do want to make sure that they're optimized properly because some people can come into your office and they tell you they're at a 13, and that was back in November, or this was back in February, and you have to wait 3 months before they can do another procedure because that's how often they check their hemoglobin status.
Right, hemoglobin A1c gets checked every 3 months. It's valid for 3 months. And the reason for it is the hemoglobin molecule gets attached to the RBC and their lifespan because they renew every 3 months. So if somebody's giving you a hemoglobin A1c that was 7 months before, it's not a valid number. You don't even have to document it. You want to know the current number, which is obtained within the last 3 months. Go back one slide. When it says usually does not require insulin therapy, it's an important sentence because there are a lot of type 2 diabetics that are insulin dependent because their number just can't be normalized by non-insulin drugs. A variety of them are out there. That is why when you write type 1 or type 2, you have to open a parentheses and say insulin dependent or non-insulin dependent. Now, type 1 is always insulin dependent, right? But type 2, you have to open a parentheses and say insulin dependent or non-insulin dependent. And if it's type 1, you have to have an idea about your total insulin dose. Is it 50 units a day that you do insulin, or is it 65 units a day that you inject insulin? Okay?
So again, this is just a management protocol that you follow. So with these patients, you want to make sure that you see them early in the morning, both of them. You want to make sure if you are sedating them that you know what their protocol is. So if they need to take their long-acting insulin the night before. Some patients, especially the type 2, they can defer to taking their metformin. That's usually the medication they say right after the procedure. But if it's to the point where they've been severely hypoglycemic, one thing I recommend for everyone, if you have in your office some type of juice or some type of sugar that they can have, because that can help raise your sugar levels. But you want to monitor monitor them, put them on pulse ox, put them on, you wanna check their breathing rate, you wanna check their blood pressure, constantly have them on a monitor. Talk them through surgery, because again, these patients, because they haven't eaten, their sugar levels are starting to get low. They can become easily like dizzy and, lose consciousness, so it's very important to monitor them. So for adrenal insufficiency, there are two types mainly, and then there's adrenal crisis. We have the primary adrenal insufficiency. This is where somebody may come into your office and they have symptoms of like weakness, weight loss, fatigue, hyperpigmentation of the skin and mucous membranes. And then we have this secondary, which is from like chronic steroid use. So with those patients, there are again protocols that we have to follow. With the crisis, there's inability for them to increase the corticosteroids that they have endogenously in response to any type of physiological stress. And so with these patients, it's always important to have a medical consult, especially if they are taking steroids consistently, because that can cause suppression of their adrenal system, and we want to make sure that we have the proper protocol to follow. So with the management, what you want to do again, same steps, anxiety protocol, talk to them, monitor their pulse ox during and after surgery. Sometimes they might have to take a daily dose on the day of, before, and after surgery, and then that can also be determined primarily by their primary care doctor. On the second day, however, then they have to either go up on their dose depending on which type of corticosteroid they are taking. So it's important that you also have that written out for your patient, like, okay, this is what you take the day before, this is what you take the day of, this is what you take after, and then however they need to get back to their dose that they are on, because we taper them from their standard dose. And so I would say this slide is very important because there are different patients that come in and you would see them and you have to know which dose to give them as appropriately needed. Another thing that we see are patients that come in with hyper and hypothyroidism. So with hyperthyroidism, we have thyroid toxicosis, which is a result of the excess circulating triiodothyronine, which is your T3, and thyroxine T4. So they're circulating in the system excessively. This can be caused by what we call Graves' disease. So they have bulging eyes, or they can have like a thyroid adenoma. And they present in different ways. They have early and late symptoms, restlessness, nausea, abdominal cramps are the early symptoms. So you might want to just clue into them if they tell you, oh, I do take this type of medication because I have this disease. If they present like this, then there could be something else going on. You want to stop whatever you're doing, sit them up in the chair. Later symptoms that may or may not present in your chair, but that could be high fever, they're sweating profusely, their heart rate is going up. So you just want to make sure that you can either defer the surgery if they're like, I do have hyperthyroidism, I don't know what my medications are, I don't take it daily, yada, yada, yada. You don't have to see that patient that day. You write them a medical clearance, you're like, you're not optimized properly and I don't want you to go into a crisis in my chair. Same thing with them, you want to limit the amount of epinephrine use and just monitor them before you treat them. I am a standard, if a patient tells me, this is what I take, this is what I have, but I don't know what I'm taking, automatically I'm writing you a medical clearance, because now you can even give me a true history of what it is that you're currently on. So that's just my rule of thumb. Same with hypothyroidism. So there's not excess of those hormones. There's less of those hormones circulating in the system, and they can present with symptoms such as fatigue, constipation, weight gain, hoarseness, headaches, menstrual disturbances. If their symptoms are mild, you don't necessarily have to adjust your treatment, but if they have excessive symptoms where like this is a constant daily concern for them, then you have to again follow the same protocols, have them get a medical clearance if they need to monitor them so that you can make sure that they're properly optimized for surgery. So now going on to coagulopathies. So we're talking about hereditary coagulopathies. There are various blood diseases that occur that are inherited that people mostly know of because they've had to mainly deal with this majority of their lives. Common ones being like history of nosebleeds, if they bruise easily, someone who has heavy menstrual bleeding, or they just bleed spontaneously. So they might not be forthright with you. Sometimes you do have to go further with asking certain questions and asking open-ended questions that patients do feel comfortable telling But then there's some specific deficiencies that you might notice where, somebody can say they have hemophilia A, B, C, or they have a variation of the von Willebrand disease. So that means that they're not able to clot with their blood. So they have an issue of constantly bleeding, and there are different ways to treat them. Again, if a patient tells you this, automatically your alarm in your brain should be going off like, okay, this patient might need to be on some type of desmopressin for their ADH, or they need to be on an antifibrinolytic agent such as Amicar. So it's important that you also get their blood labs. So you want to get them a CBC, you want to see what their platelets are, you want to see what their red blood cells are, their whole differential. You want to get an idea of that before you treat them. And so with that, you want to have a baseline test, like they stated, what their bleeding time is, what their platelet count is. That way you can know what their risk for clotting is, if they will. With surgery, now you can think about, okay, if I take this tooth out, do I need to put gel foam in there so that it can help with the bleeding effect? Do I need to put a type of agent that will help stop the bleeding in the socket? So like TXA, etc. So these are things you want to think about when you're treating these patients. You also want to keep them in your office. It says to manage the wound for 2 hours. I know that seems like a long time. I would say at least 30 minutes. Just keep them in your office, make sure you're monitoring them, see that they're actually not actually bleeding before you discharge them from the chair. Because if you send them home, most patients, they're just like, okay, I just went to sleep, and then they wake up like, oh, I'm bleeding. Then they're gonna go to the doctor's office, they're gonna go to the emergency room, and which is not bad because you want them to go seek treatment in the emergency room. But at least if you have an idea, so okay, this patient, I know I discharged them in my office and they were stable before they left, it at least give you some comfort at night so that you at least make it your rest. And then there's some patients who may be on blood thinners, like we discussed earlier, people with like certain heart diseases that might be taking Coumadin, which is warfarin, or they might be on, they might be on aspirin, or now there's these dual antiplatelet therapy medications that you hear about. So you always want to consult that physician, get their INR, especially for someone who's taking warfarin. You want to get their INR, make sure that's their internationalized normal ratio. You want to get that and know what their baseline INR is. If it's more than 3, then you need to get a consult with their primary care doctor. You want to stop the warfarin 2 days before surgery. And again, these are all protocols that their doctor will give you because there's certain guidelines that have changed recently. And then they'll tell you, okay, then the patient can start back up after the day of surgery. Same thing with someone who's getting heparin or someone who's taking aspirin. Baby aspirin, there's not too much of a concern. That's 81 milligrams of aspirin. But if you're taking higher doses or taking other medications, then you want to make sure that you have the proper protocol of them stopping it.
Does anyone know what is that higher dose is? So if somebody is not taking the baby aspirin, which is 81 milligram, what is the other aspirin dosage that is available that people are prescribed? Know that. Should. Anyone? 325 milligrams.
So this is just a diagram I saw from the Journal of the California Board. I'm just trying to find something that is new that we're kind of following on a protocol for doing any bleeding procedures. This is just for your learning. It's not something that you have to know, but I think it's important to kind of have an idea of if someone comes into your office and they tell you, oh doc, I'm taking this, and then they're in severe pain, you want to help them out. There are different things you can consider to help them before taking the tooth out without having to send them to get the medical clearance. Sometimes it is tedious for a patient to go to their doctor's office, get a medical clearance, come back to you, get the procedure, and it might take a week or 2 when they're dealing with this tooth that's causing them so much pain. So it's just for you to use your better judgment. Okay, if it's going to be high risk bleeding, am I extracting more than 1 tooth? Okay, no. Then you can treat it with some type of therapy. Or if I'm having to do more teeth, I can arrange multiple appointments and things of that nature. So, and then the ADA also has good guidelines as well, so it's important to look at those because everything's changing pretty frequently. So somebody might come into your office, they tell you, oh, they have a seizure disorder. That means there's some irregular patterns that are going on with their brain function. So these people tend to have a frequency to what we call pass out, or they're just tense up, or some people might just blankly look at you and their brain function is constantly going. So it's important to ask to what type of seizures they have and if they're able to deal with those seizures on their own without the help of somebody else. Because some people are like, oh yeah, I can't drive. So then that puts you into like, okay, this person's seizures are not controlled the way that they need to be. And sometimes they might need to, if they're going under sedation, they might need to take it that morning with small sips of water to prevent them from going into some type of seizure arrest. And then you want to make sure that you have proper documentation. You want to make sure that you have their serum levels for the medication that they take. So if somebody is taking Keppra, which is a common seizure medication, you want to make sure you have those levels of their Keppra in their system to make sure that it's properly working. And you guys are in pharmacology now, right? You're probably going to learn about seizure medications down the line, but when they start talking about it, these are important things you want to think about. And alcoholism, so more than likely, it's very rare that somebody will come into your office smelling like alcohol, and it will happen. But that's something that you also want to factor in as well, because the way they metabolize drugs is different. So when your social history, again, that's important. Somebody tells you they drink, you want to know, okay, how many cups do you drink? Is it beer? Is it wine? Are you taking shots? Like, are you drinking, every day, every week, socially, which is like every other month? Because that will clue you into the severity of their alcoholism. And with these patients, they can have some electrolyte abnormalities, they can have fatty liver or some type of issue going on with their liver that's not allowing them to metabolize things a certain way. And then alcohol also interacts with medication. So it's very important that you get a good, thorough history from your patients. And then going into our pregnant population, again, so these patients come in, we want to turn them to their OBGYN before we consider treatment, but there are things that we can do to help them out. So we always want to know how far along they are in their pregnancy. If they're in their first trimester, it's very risky, so you want to defer any type of treatment to second, preferably. You want to make sure I know the ADA has dropped new regulations on the use of protectors for dental imaging, but with them, you just want to be careful. Put a lead apron on. You don't want any risk to baby for fetal damage. If needed, you want to make sure that whatever medication you're giving them, so local anesthesia, which on the next slide will show, you want to consider certain anesthetics before you use it, because that can have an effect on the baby as well. So that's what we call a teratogenic effect of the drug. So you want to make sure that these medications you give them, whether it's antibiotic, pain medication, local anesthesia, you want to make sure that it has no effect on mom and baby. So these are drugs that you can give. So these are least likely. You can give them lidocaine, bupivacaine, Tylenol, penicillin. You want to avoid your NSAIDs, any sedative drugs. Nitrous in the first semester, you want to avoid that. But anything you do with a pregnant lady, you want to get clearance from her OBGYN. Most of the time with pregnant women, they are good about getting the clearance before they even come to you. So they already know that, okay, this is what I need to show you for you to continue treatment for me. And these are, again, just a side-by-side table. So again, when you're thinking about postpartum, there are medications that mom, if you give it to her when she's breastfeeding baby, it can have an effect on baby, and then have an effect on the development of their oral hygiene, oral teeth, or just anything within their body. So you want to consider certain things like Tylenol, again, has no effect, certain antihistamines, but once mom starts breastfeeding, ampicillin is now considered to be harmful for kids. Same thing with penicillin, which when mom was pregnant, it was fine, but now postpartum, she cannot give that. She cannot have that type of medication because it will affect baby from her breastfeeding. So these are the medical conditions. So now, continuing on with our preoperative evaluation. So you want to ask the patient, do you have any past surgical history? What type of surgery did you have? What was it for? How did you have any complications? How was your healing process? Because that'll also clue you into how they heal. Something that I also mentioned with diabetes, it's important to know their A1C, because that will also clue you into how good they will heal once you do a procedure for them. Again, social history, you want to ask them, how many cigarettes they smoke. Is it a pack a day, 1 cigarette a day, 1 cigarette, a couple days? Some people can ask, you want to know how many years they've been smoking. Same with illicit drug use. Do you use marijuana? Do you smoke PCP, heroin? Like, you want to ask them all these questions. People laugh and they look at you like, why are you asking me that? make sure that however I treat you, I know the proper protocol to follow. And same thing with alcohol use. You wanna know what type of medications they're taking, so somebody will tell you, I'm taking something for hypertension, it's a gluco. That does not help me. I need to know exactly what's the name, what's the dose, the last time you took it, how frequently you're supposed to take it. Because again, especially patients who have hypertension, they have diabetes, they might have to take something in the morning, something at night. Another thing too is patients who have anxiety. They may be taking something at night, they might not know. And people don't think to mention if they have any type of anxiety, depression as a medical history, so I tend to just ask them specifically. If they tell me, oh, I don't have any medical history, do you have any history of anxiety, depression, then you need to take any other medication for, and then you can get that information from them as well. Allergies are very important to know, because common thing is you want to make sure that if there's an emergency in your office that you're properly prepared for that emergency. So you want to make sure if you need to give somebody an EpiPen that you can give it to them appropriately, but you won't know that unless you have the proper documentation. So if someone tells you no, they're not allergic to anything, go deeper. Okay, if you take penicillin, what happens? If you take Tylenol, can you tolerate it? Can you eat peanuts? Like, these are different things. Are you allergic to eggs? Because sometimes in the medication that we give, propofol, there's certain ingredients in it that might cause a reaction. Vital signs are important to check as well. Like I said, we talked about blood pressure. You want to get their blood pressure, their heart rate. You want to get their pulse ox, so just how they breathe on room air. So you just want to see all that. And then now you go into your physical exam. And you want to follow these 4 steps: inspection, palpation, percussion, auscultation. I know you guys said you've had a HRP course, but it's very important to look at the head, look at the ears, the eyes, the nose, the mouth, the neck. You want to also palpate, so palpate their joints, palpate their sinuses, palpate around their mouth, their floor of the mouth. Percuss, we don't really percuss, but more so for the teeth. See if they have any tenderness to any of the percussion. And then auscultation, you want to hear if they have any clicking or popping in their joints.
We're out of time now. I have a session dedicated for review, so anything I didn't cover, I will cover. But I think the remaining slides are pretty straightforward. Please read them. But we will have a whole session, right? One class dedicated for review. The one with the blood disorders. If you guys remember, there was warfarin and heparin on that slide, right? It says coagulopathies. You remember that slide? So when you read that slide, you have to read it multiple times, and you have to kind of do a little bit investigation, because it tells you warfarin, something, heparin, right? It's the most summarized version of the topic. In your D3 year, each of them will be one lecture, like the renal, cardiovascular, they will each be like one lecture. And at this time, it is only the history taking, right? Part 1, chapter 1. But still, you have to do some additional reading to understand what has happened, what is warfarin, why is it, how is it related to clotting. Any questions? Any questions? No? Okay. Gather your questions, because we will have a time, right? The last lecture is a review session, lecture before final. So all the lectures, whatever questions you have from all the lectures, that time is dedicated to answer them. Right? All right, very good. Thank you so much.